She did fellowship in preventive cardiology and clinical lipidology in 2016 at McGill University in Canada. Dr. Al-Kindi is awarded American Board of Clinical Lipidology from the United States in 2016. She is a member of National Lipid Association and board member of Oman Society of Lipid and Atherosclerosis. She is working as a chemical pathologist, senior consultant at Royal Hospital in Muscat, in Oman. Welcome, Dr. Manal, and now you can
your lecture.
Thank you, Doctor, for a warm introduction, and thanks for the Society for their great opportunity to share with you some issues related with the CA19.9. So let me start first with a case. So this is a 50-year-old man who was admitted for the evaluation of a painless jaundice and weight loss. His CT scan showed no mass. He went through the ERCP brush cytology, which reveals some malignant pancreatic ductal cells. The histology proved stage 1 pancreatic head adenocarcinoma in a tumor which is less than 2 centimeters in diameter. The preoperative CA19.9 was around 120 and it's dropped to 89 post-operatively. So the patient received adjuvant chemotherapy. His CA19.9 decreased to 40, but however, gradually it rose to 100. So he again go for another chemotherapy, which resulted in normalization of his CA19.9. And since the origin of the diagnosis, the patient had that fluctuation in his CA19.9 with no significant clinical symptoms and of course, negative staging on PET scan and CT scan. So to prevent relapsing in CA19.9 and prevent metastasis, he went for another aggressive chemotherapy. Later, the patient was admitted with the history of melena and anemia. So he had endoscopy, and his endoscopy showed a bleeding peptic ulcers with elevated CA19.9 of around 100. So the patient was started on protein pump inhibitors, which result in dramatic reduction in his CA19.9. And since then, there is no much fluctuation in his CA19.9. So just remember this case as we walk through the presentation. So what is pancreatic cancer? Pancreatic cancer happens when you have a cancer cells form and grow within the pancreas. The tumor is hard to diagnose early because the sign and symptoms is not obvious. So the majority of the cases, usually they diagnose when the disease is already have reached an advanced stages where the treatment options is really limited. Only 20% of people who have peptic ulcer are operable for cure. And despite there is a major improvement in the surgical technique on the chemotherapy regimen and the introduction of a new adjuvant chemotherapy, the 5-year survival from the disease is low as 2% in some countries. And the optimal screening test is still to be identified. This is from WHO, just show you the number of the new cases of pancreatic cancer in 2018 for both male and female across different age. Just, I hope you can see the number. Look to the number, the pancreas number of cases. If we have to move to the number of deaths on the same year, 2018, the difference in the number between the diagnosed case and the death rate is not much significant difference. This is just to show you the prevalence of the disease across the globe. This is for the male and this is for the female. So we're talking about pancreatic cancer. So what are the risk factors? It's not specific risk factors. Some of them are specific, but smoking, diabetes, pancreatitis. There's a family history of some of genetic syndromes like a BRCA genes or the FMMM syndrome. If there's any family history of pancreatic cancer, if obesity one of them, and it's a disease of older age, so most of people, they are diagnosed after the age of 65. The type of pancreatic cancer would depend on the cell type. So if it is originated from exocrine cells, it gives you a pancreatic ductal adenocarcinoma tumor, which is the most common. If it's coming from endocrine cells, so then you get the pancreatic neuroendocrine tumor and pancreatic endocrine tumors. The pancreatic adenocarcinoma and its variants account for more than 90% of all the pancreatic carcinoma. How does it present? Unfortunately, the signs and symptoms of pancreatic cancer doesn't occur until the disease is really in advance, and it's non-specific. So they may present with abdominal pain, loss of appetite and weight loss, jaundice, staturia, dark colored urine, itchy skin, or a newly diagnosis of diabetes, or worsening control of a pre-existing diabetes, blood clot and fatigue. So it's non-specific. How we can diagnose? There's not much we can gain from physical examination. However, imaging modalities such as CT, MRI, MRCP, and endoscopic ultrasound can help. Some of the biochemical markers like CA19.9, and of course, the gold standard for the diagnosis remains histology by finding the diagnosis from the histological examination. So, what is CA19.9? It's a carbohydrate antigen, a glycoprotein antigen that defined by a mouse monoclonal antibodies 116 and S99. So from here the names came. In the plasma, the CA19.9 exists as a high molecular mucin glycoprotein, which contains the sialylated Lewis A epitopes, lacto and fructobenzose 2. The 5 to 10% of population, they have a blood type Lewis negative. So they lack the fucosyl transferase, which is required for the expression of CA19.9. CA19.9 present on the epithelium of fetal stomach, intestine, liver, pancreas. There's a trace amount can be detected on the adult gastrointestinal tract and lung tissue. So healthy people, they can have a small amount of CA19.9 in their blood. The half-life for CA19.9 in a healthy people is around 4 to 8 days. And the main clinical application for CA19.9 is to monitor the pancreatic cancer. What is the guidelines? This is from National Academy of Clinical Biochemistry for the use of 19.9 in patients with pancreatic adenocarcinoma. First of all, it's the most widely used and best validated marker in pancreatic cancer. Inadequate sensitivity and specificity have limited the use of CA19.9 in early diagnosis of the pancreatic cancer. And in a patient who is non-jaundiced, CA19.9 may complement other diagnostic procedures. Patient with resectable pancreatic cancer, the pre-surgical and post-resection on CA19 level may correlate with the overall survival. And the serial level of CA19.9 correlate with the response to systematic therapy. The use of CA19.9 kinetic in conjunction with imaging is recommended in monitoring therapy. So, although there are several potential serum and tissue markers for pancreatic cancers, which is undergoing evaluation, I'm not sure if it is clear, you can see, but there is a lot of serum markers, including TBA, CA242, and there is a lot of other tissue markers like KRAS and B53, in addition to microRNA, which is being validated right now. But unfortunately, none of them being validated enough to be used in a routine clinical use. And so the CA19.9 remain the serum pancreatic cancer marker against which any new marker will be judged based on the existing marker, which is CA19.9. What does FDA say about 99? The CA19.9 is the only marker approved by the FDA to be used in a routine management of pancreatic cancer. However, the low positive predictive value of CA19.9 means it has no role in a mass screening of symptoms in a symptomatic patient, and it's only used for monitoring response. What are the types of tumor markers? We've been talking about tumor markers, so the whole session is talking about markers. It could be hormones such as beta-HCG. It could be enzymes such as PSA. It could be proteins and glycoproteins such as the carbohydrate antigen like 99 and 15.3. It could be oncofetal antigen like alpha-fetoprotein. It could be receptor like what Dr. Leila was mentioning about estrogen receptor and progesterone receptor. And it could be genetic changes, just a mutation and translocation. What are the ideal tumor marker? What are the characteristics of an ideal tumor to be used? We want the tumor marker to be highly specific, so it's only detectable in only one type of the tumor. We want it to have high sensitivity, so it's non-detectable in physiological and benign disease status. Remember case 1? We need a long lead time, so that there is a sufficient time for alternation of the nature course of the disease. And we need a marker where the level correlates well with the tumor burden. So there is a prognostic and predictive utility of this tumor marker. Short half-life is important because we want a frequent serial monitoring of the marker level after 5 or 6 half-lives. For us in the lab, what we want a very simple and cheap test. We want a test where it's easy to obtain the specimen. This is the characteristic of an ideal tumor marker. Let me take you to case 2. 60-year-old female admitted with epigastric pain, painless jaundice, pruritus, and weight loss. Physical examination, no abnormality apart from her jaundice. Her LFT show obstructive jaundice. However, her CA19 was 18,000. Her abdomen ultrasound showed multiple stones in the gallbladders, and probably there is a 13-millimeter stone on the distal cystic duct, but there was no signs of adipocystitis. During her admission, her LFTs improved spontaneously, and patient was discharged waiting for cholecystectomy. While waiting for the cholecystectomy, she was admitted before that because of the relapse of her painless jaundice. Abdomen CT and MRCP again show only CBD or stone on the common bile duct, but there's no malignancy. She developed cholangitis, and at this time, because it was difficult to remove the stone, they put a biliary stent. Her CA19 decreased to 45 after biliary stenting. She was discharged. Unfortunately, after 1 month, she admitted because the stent was moved or displayed from the place. So the CA19 was more than 10,000. Again, they have the stent placed again, and the CA19 come back to 45. Eventually, she went under cholecystectomy, and the stone was removed. There was no sign of malignancy, and after that, the CA19 remained back to the normal, never raised again. This is just to show you how the level, you have the CA19 and you have the total bilirubin. Whenever the bilirubin is high, the CA19 is high. Put in the stent, everything's improved, both the bilirubin and the CA19. The specimen goes back, and then after surgery, everything is back. So is the tumor marker really an ideal marker? CA19 is an ideal marker. There are clinical caveats in using CA19 as a diagnostic marker, and there is an issues related to the measurement and interpretation of CA19 level. Let's talk about the clinical caveats in using CA19 as a diagnostic aid in pancreatic cancer. There are several benign diseases may increase your CA19 level, including the chronic and acute pancreatitis, liver cirrhosis, and cholangitis. Remember case 1 and 2? The other things that CA19 can be increased in multiple types of adenocarcinoma, especially in the advanced gastrointestinal cancer. In one of the overview studies, the CA19 was increased in bile duct cancer, gastric cancer, colorectal cancers, esophageal, and hepatobiliary cancer. So it's not specific to pancreas. The other things, as I mentioned before, the CA19 is not expressed in subjects who have a Lewis negative genotype. So the molecules in which the CA19 epitopes is found is in the sialylated Lewis A blood group. So those subjects, they have a negative Lewis, so they are not expressing the CA19. Caucasian, probably 5 to 10% of them they believe to have a Lewis negative. I'm not sure about the Arab population. I don't know how common it is. The CA19 lack the sensitivity for early and small diameter pancreatic cancer. Now, only 50% of the patients with the peptic ulcer less than 3 centimeters, they have elevated CA19. The other really differentiated cancer, they may not increase CA19. So this is the limitation. So CA19 cannot really replace the histological proof of pancreatic cancer. Biological variation. The intra-individual biological variation plus the analytical imprecision in one of the studies calculated to be around 40 to 50%. So you need a 40 to 50% change on the serial level to suggest and indicate that there is a clinical significant change in your level of CA19. What about the issues related to the measurement? One of the issues, which is number 1, there is a lack of international standard for CA19 and different assays design. So different assay may give you different results. And so it is important that you report the CA19 level, stated the method. What are the methods that you use? You have to state it with the report. For a patient undergoing serial monitoring, the same method should be ideally used throughout the treatment. If the method has to be changed, which is very common in most of the labs, the CA19 level should be determined in 2 to 4 serial specimens using both the old and the new method in order to establish the new baseline. And in consequently, Boolean comparability of CA19-9 result obtained using different method, it's complicated the interpretation, particularly if the different assays are used to determine serial level of the marker. This is from EQA, and I guess it's small to say, but this is from RECAST. This is an external QA just recently, the last cycle from our lab. And if I have to zoom to different methods here, this is the same sample measured in different labs. It varies from 50 to 250. Different labs measure different level. The other issues with the tumor marker or CA19-9 is the cutoff. So it depends. What is the content that you're trying to answer? What is the question that you are trying to answer? Will depends on what cutoff you use. If you use 37, it appears to be a best to discriminate between benign and malignant. That's fine. But if you want to determine prognosis and the optimal cutoff point still is unknown. But it's clear depends on whether the measurement is made pre-operative or post-operatively. For post-resection value, the level between 90 to 200 have been reported to supply independent prognostic information. There is a data from 24 studies say that use 37 as a cutoff was found to have an over-mean sensitivity of 81% with a specificity of 90%. If you increase your cutoff to 100, you improve the specificity to 98, but you drop your sensitivity to 68%. However, if you raise your cutoff to 1,000, you're jumping your specificity to 99.8, fantastic. However, you are reducing your sensitivity to 41%. Issues number 3, it's an immunoassay. So there is an assay interference like all immunoassay, as what Dr. Hebes explained in her first presentation. It could be heterophile antibodies, it could be rheumatoid, it could be hook effect. This is a 61-year Caucasian man who was suffering from fatigue and weight loss. The CA19-9 was 80 on the Advia Center, but when they measured it on the AXM and Architect I2000, it was normal. The patient's rheumatoid factor was high as a 900, and you can see here the fluctuation. The triangle is the rheumatoid factor, and the circle is the CA19-9. Whenever there is a high rheumatoid factor, the CA19 is high. Whenever the patient go on remission and the rheumatoid factor decrease, his CA19-9 decrease. So there is an interference from rheumatoid factor on the method on that lab. This is a long case, although I really like it. There is a lot of things you can learn. 76 man complaining of pain in his right upper quadrant pain. The ultrasound show hepatomegaly and biliary polyps, and CT show the same. The CA19-9 was 395, and the other testing result was unremarkable. His rheumatoid factor was 122. And when they measured the CA19-9 on a different platform, like on the AXM using MIA and on the Roche using the electrochemiluminescent, the CA19-9 measured was normal. Although it's in the AXM, it really was high. So with high rheumatoid factor, then probably they thought it could be an interference from rheumatoid factor. So what they did, they treat the serum sample by incubation at 60 centigrade for 30 minutes, and that will eliminate the rheumatoid factor. And then they measure rheumatoid factor in dead bearing analyzers, where it's reduced from 122 to 10. So the rheumatoid factor interference being removed. The CA19-9 was measured on the AXM again, and it was decreased from 1,047 to 423. So good. But the question is, does really the incubation affect also the CA19-9? Was it really reduced because of the incubation, not because we removed the rheumatoid factor? So what they did, to rule out that effect, they took the serum from CA19-9 from patient known to have a high CA19-9, and they incubate the serum. If you look here to the white bars, this is our before the treatment. The black bars is after the incubation, and this is different CA19-9 with different concentration. There's no much differences after the incubation. So the incubation didn't really affect the CA19-9. So removal of anti-rheumatoid factor is the reason. Let's confirm that. To confirm that, they took 18 serum samples from patients who have a very high rheumatoid factor, and they measured the CA19-9. Unfortunately, the CA19-9 was normal on those people who have a high rheumatoid factor on the AXM. So the question, so it wasn't really the rheumatoid factor was causing the interference. Further questioning of the patient, he gave a history that he was living on a farm, and so there's a large number of mice surrounding him. So of course, the suspicion that it could be heterophile antibodies and the patient's serum that might increase the CA19-9. And to treat it, as we all know, that they incubate the patient's serum or non-immune mouse serum and precipitate it with the big precipitation. When they use 20% of mouse serum to the patient result, the CA19 dropped to 162. When they use 50%, it's dropped to 19.8. So it is the interference from the heterophile antibodies. Issues number 4 is the linearity. There is a nonlinear dilution, which increases the recovery of the antigen, very common in immunoassays, especially for the mucin. And the reason for that, it could be because there is a high level of anti-carbohydrate antibodies in the mucin, which generates complex, or the mucin itself have the property of aggregate and disaggregate as a range of molecular species, or it could be a matrix effect, but it is an issue on the linearity. I'll show you this case, which I come across it, which was for me a surprise that they report a 66-year-old diabetic female. Her serum level or her serum 99 level was really parallel her HbA1c. At the beginning, I thought it could be pancreatic cancer, so they screened her and they did all the investigation, and it's proven to be a falsely elevation in CA19. And they noticed her CA19 fluctuates between 58 to 235, whenever her HbA1c fluctuates between 7 to 13. So they grabbed a 73 diabetic patient, 36 male and 37 female, and they proved that the 1799 was really higher on this group, especially on the female. And then they evaluate that, and the question is why it is. And the mechanism they report that it could be hyperglycosylation. I found another paper which talk about the mechanism of why it's being elevated on serum. CA19 was elevated in diabetic patients. And this is published in the Endocrine Journal in 2013. If you have a time, go through it. I'm just going with I'll jump to the conclusion for the sake of the time. On that paper, they conclude that it could be the half-life of the serum CA19 was longer in the patient who won't reported longer in the patient who have a diabetes compared to the patient who report having malignancy. So diabetic patient show prolonged half-life of CRM99, which is contributed to the increase in their CA19. This is another paper just talking about CA19 increase in insulin resistance, and this is from the region. Then I'll take you to case 6. This is 52 women presented with epigastric pain, anorexia, nausea, weight loss. She has unremarkable past medical history. She's not a smoker, not consuming any medication, and not consuming alcohol. Her physical examination was normal. She gave a history of overconsumption of a warmed black tea for several months. She tended to consume around 1.5 to 2 liters per day. All her investigation was normal. Her autoantibodies was normal. So they did CA19 for a reason, I don't know, but it was done as a part of the weight loss investigation. And it was around 1,432 with the CA around 2. They do all the imaging. They didn't identify any source of that. And then it's clicked that she's consuming a lot of tea, black tea. So they advised her to stop. And after 4 weeks, they reassess her CA19, which was dropped to 42. And actually, the patient also say that she gained 2 kg during that four weeks. And to prove it, she went through a re-challenging. So they asked her to go and consume high amount of black tea as what she did before. And after 4 weeks, her CA19 jumped to 745, and she got the same symptoms. Ask her to stop, her CA19 dropped to 25. So, and after 1 year of follow-up, there is no clinical abnormalities. The abdomen and CT scan were all normal. CA19 was normalized. So I was thinking, is that the only case, or is something by accident? I dig in the history, and there is a paper which is coming really from our region, where they talk about the interference effect of consumption of high black tea and the increase or the interference in CA19. And in this study, they include around 270 people who really consume a very high amount of black tea. And they noticed their CA19 in increase. Some of them reach 100 and above 100. And they come with their mechanism and theory or hypothesis, which I'm not sure which one is them. I have one which is, I think it's more convincing, but I'll tell you the two theory. The first one, they say maybe there is an increase in CA19 because there is a stimulation or there is a hemolysis in RBCs. But we know that the black tea has no hemolytic effect on the blood cells. Actually, its work as give a protection to the RBCs from the hemolysis and from morphological alternation, where as an oxidative agent. So black tea is an oxidant, so it's good for the RBCs. The other theory, they said, it's maybe stimulate more production of CA19 from the epithelium tissue. We know at low concentration, black tea and its content probably have some protection on the epithelial layer of the GI from the harmful compound. But a high concentration, it causes and induces apoptosis and cytolysis in the intestinal epithelium. And I find this probably more convincing theory why it can increase the CA19. I'm not going through case 6, but just tell you briefly, I find it really interesting because we work in the lab. We have always to think beyond the box. We always have to find the different cases which doesn't make sense as an area for us to dig. Patients have a high CA19 in one platform, not on another platform. They investigate all the interference. But in this case, they did thin layer chromatography, or they did gel filtration for the patient serum. And they identify a low molecular weight, which is causing interference of CA19 in that particular method. So given all that about CA19, probably we need an identification for a new biomarker. And in 2008 in Science, John and his group carried a comprehensive global gene analysis on 24 patients, and they involved more than 23,000 transcriptors as well. They identified over 500 genes, which at least 10 times overexpressed in more than 90% of the cancer patients. And 54% of the gene encoded protein that were predicted or secreted overexpression on the cell membrane. So these overexpressed proteins should provide really valuable resources to identify new markers that therapeutic target for patients who have pancreatic cancer. So the take-home message, we know pancreatic cancer is a biologically very aggressive tumor from the onset. CA19, excellent marker for monitoring patients with pancreatic cancer, but cannot replace histological proof of pancreatic cancer. There is a lot of clinical caveat in using CA19 in diagnosis, which we discussed through the presentation, and the measurement and interpretation of CA19 have a lot of pitfalls that should always bear in mind. Given the limitation of CA19, there is a need to identify new markers, and the identification of a novel biomarker is desirable to move toward the precision medicine era, which a pancreatic cancer therapy can be tailored to the individual patient and avoid unnecessary treatment. Please remember all the cases, pitfalls, and the caveats, clinical caveat. Thank you very much for your interest and listening.
Thank you very much, Dr. for excellent presentation. I will go on to the questionnaire. And we have 10 minutes, and I want to invite all the 3 speakers, Dr. Hiba, Dr. Layla, if you can join us for the questions. اهلا وسهلا. دكتورة باقي هبة. اوكي دكتورة هبة اهلا فيكم جميعا. الاسئله موجوده في اعتقد في شات كل واحده من الزميلات. للاسف انا عندي نفس مشكله كدكتوره منال، كان اللابتوب شغال الى قبل 20 دقيقة من السيشن. For some reason it's not working. وبعدين I moved to iPad now. والايباد ما يظهر الكويشنير. But let's wait. Is there any questions? No? طيب let's start with دكتورة منال. The last questions about the black tea. Usually, Doctora, always what they studied, what we the green tea always about. They give like some studied about green tea, but the black tea. I mean, why is it the black tea has this I mean benefit?
Which is there.
Unmute Dr. Manal.
Dr. Manal.
So the black tea. نعم. You can hear me? اسمعوني؟ أيوة. So the black tea itself, it has one of the compounds which causes a protection, but not in a very high concentration. Assuming somebody is consuming 2 liters per day, and it depends, is it really the black, like how much tea is there? Is it like the light tea that we drink, or it's a heavy black tea? So when it's a high concentration, it's a harmful. So I assume one of the compounds inside it, which is either stimulate the epithelial to secrete more CA19.9. It's different than green tea, but we're talking about the black tea.
To Dr. Manal and Dr. Layla, what advice do you give clinical pathology residents interested in precision medicine and molecular pathology?
This is the future. Actually, this is the present. Go for it. I think basically there needs to be emphasis on genomics, studying of genomics, genetics. There has to be really, because this is truly the present and it's going to be the future.
We need to move. We cannot treat everyone as the same. We are not the same. We are different. And if you see a lot of patients, you will see we are different. Whatever is causing harm on somebody, it doesn't cause the harm on somebody else. Why? Because we are different. So we have to move. We have to tailor people. We can't use one for all. It's been used in the past, but it's not working. And unfortunately, the more we understand, the more the people do more research, the more you involve on that trials and things, the more you understand it, and then we may serve the patient better than before. I think we need to move. And I think we don't have the choice. I think the whole world is moving, and we have to just catch up.
Maybe I think Dr. Hiba, it's to have qualitative, positive, and negative, supported by quantitative BHCG result from the same patient with 4 hours period between 2 blood samples. Is it the question is clear, or you want me to repeat it again?
Well, actually, I'm not sure. He wants to do both quantitative and qualitative. Send 2 specimens, basically. One for quantitative testing and one for qualitative testing. And have the result within 4 hours. I'm not sure what is the clinical indication, like HCG to have, well, the setup or selecting the method will depend on the clinical need. And I show different examples, like the cancer center, for example, where you see patient with secreting HCG in their serum coming from the tumors, and they are not actually positive for pregnancy, but it will give you false positive. Now, selecting the method that is right for such patient is very important. Now, for those, might be you select the intact, not the one that you measure beta HCG, because these kind of patients will have beta HCG in their serum. Now, why do you want to do 2 different methods to have the same result at the end at the end? Now, you're looking for a screening for pregnancy, or you want it as a tumor marker? Having a quantitative or qualitative, now again, it has to answer a certain clinical question, what actually the clinician looking for. But sending both of them, I don't think it's cost effective, as well as it won't answer the clinical need unless we are investigating a certain case by itself. I hope I answered that. It's,
Thank you very much. I think there is no more questions. I would, at the end of this session, thank all the 3 pioneers really presentation and thank you very much also for the audience. And we have, I think, about 4 minutes for break. Then we'll move into the 3rd session. Thank you very much.